Wonderful. Good morning, everyone, and welcome to our spring speaker series hosted by the Twin Cities chapter of the Foundation Fighting Blindness. My name is Andrea Harper. I'm the chapter engagement manager supporting our Midwest, Heartland Midwest chapters. I'm so excited to be with all of you today. Thank you for sharing your Saturday morning with us. And before we get started, I'd like to briefly review some logistical details for today's call. Hopefully some of this is helpful to you. Currently, all participant microphones are muted. Today's call is being recorded and will be shared with all registrants after the meeting concludes. If you are using a screen reader, please be aware that the controls are at the bottom of the Zoom interface. This control bar may collapse when not in use, so please make sure to move your mouse before clicking anything. To turn on the Always Show Meeting Controls setting in Zoom, you'll want to click on the General menu in Settings. Always Show Meeting Controls will be the sixth choice to select. Let us know if you have any questions or need help with any of this. You can put your questions in the chat. We will be using the chat feature today, or we'll have time later on if you'd rather come off mute and verbally share your question. We have a great program for you today. We're planning for a little over an hour, maybe close to 90 minutes of learning together. Before we introduce our guest presenter, I'm going to briefly tell you a little about the Foundation and the chapter network. We're going to hear very briefly from Foundation staff and the chapter leadership team, and then we'll dedicate the rest of our time to our guest presenter. So hopefully that sounds good. So just to tell you a quick overview about the Foundation, if you're new to the Foundation Fighting Blindness, our mission is to drive the research that will provide preventions, treatments, and cures for people affected by retinitis pigmentosa, Stargardt's disease, age-related macular degeneration, LCA, Usher syndrome, and the entire spectrum of retinal degenerative diseases. We are the largest private funder of retinal disease research in the world. To date, we have raised over $816 million towards this research. And I think I mentioned at the beginning, I am sharing just a few PowerPoint slides, but I'm going to be reading everything on the slides, or at least summarizing what you'd be seeing. Just a little more about the Foundation. We've identified over 270 retinal disease-causing genes. We currently support over 40 active clinical trials. We've funded the first FDA-approved gene therapy for the eye, Luxterna. And we've funded the first FDA-approved bionic retina. How cool is that? Just a very brief overview of the volunteer-led chapter network. Again, thanks to the Twin Cities chapter for hosting us today. Our chapters focus on three main things: educational outreach, resource sharing, and fundraising efforts that benefit the Foundation. So we could talk a lot more about the Foundation itself, and if you have questions or want more information, please put that in the chat, or you can reach out to me or the leadership team after this presentation. So next, I'd like to introduce some of the staff that may be on with us this morning. We have including myself, Andrea Harper, we have 4 staff that support this chapter, the Twin Cities chapter. Hopefully we're going to get to meet and briefly hear from each of them and a little about their roles with the Foundation. So Linda Schellest is our Director of Events. John Corneal is our Director of Legacy Giving. And Rishi Donut is our new Chief of Human Resources. So Linda, are you with us today?
Yes, I am. Hi, Andrea.
Linda. Welcome. Hi, Linda. How are you?
I'm good. Hi, everyone. It's so nice to see you all. As Andrea said, I am the Director of Events for our Midwest region, which includes, of course, the Twin Cities. And up on the screen, Andrea just put up the very exciting event that we have on Monday. It's called Crafting Cures. It's going to be this coming Monday, the 16th of May, at the new market at Malcolm Yards. Really cool venue. We're very excited. We're going to have a great dinner, drinks, really fun games, including a ring toss and cornhole, and a fantastic silent auction with really exciting items, including 2 tickets to a Twins game behind the plate. And that's going to be for May 23rd, but we have a lot of other really exciting items as well. And then on September 24th, we'll have our Twin Cities Vision Walk. So I hope you can join us for both of them.
Wonderful. Linda, thank you so much. Thanks for being with us and
Sure.
for talking to us. We've got 2 wonderful events coming up. Thank you so much. Next up, John Corneal is with us, our Director of Legacy Giving. John, good morning.
Space audio now unmuted.
Good morning. Can you hear me?
Yes.
Oh, great. Thanks, Andrea. Thank you, Linda. Thanks for not taking full 5 minutes, Linda. That gives me an extra minute, I think. So it's great to be on this call, and I wish we could have been in person. As probably all of you do as well. I tell you that we have just really started resuming our in-person events and gatherings at the foundation, and we had one out in San Francisco maybe a month or so ago, and it was a high-level science engagement opportunity. And I'm telling you, the people that were there were just as excited about being together in person as they were with the substance of the presenters. And same thing. So I hope all of you can attend the Crafting Cures event on Monday, the other events. And what I like to do when we gather in person is to talk a little bit about what's going on at FFB, but I'll stray away from that for the sake of time today and just remind you we are a very much volunteer-driven organization. We are here today because of donations, not from the government, not from anything other than the support from people like you. So it's critically important that we continue to have the support from our volunteers. A small part of our overall budget is for things like this, public education and awareness. So it's free. You didn't have to pay anything to attend today. Most of what we do is research because that's what we're all about. That's what we all care about, are finding treatments and cures. And I'm telling you that in the time that I've been with the foundation, maybe 15 years as a volunteer and staff member, and we hear this a lot, but it's actually true. There's never been a more promising time. Andrea said that we've got our hands in over 40 clinical trials. We actually are involved in funding over 80 projects around the world at the present time. So there's many ways that you can help the events, online donations, the chapters. You can volunteer your time, but legacy giving is a growing, huge potential source of revenue for the foundation. And basically, in short, what that is, it's a gift that you make to the foundation that comes to light upon your death. Not a fun topic to talk about on a Saturday morning, not ever a fun topic to talk about, but it's going to happen to all of us. And I don't know all of the people that are on this call, but I suspect that some are on here have created a legacy gift already in favor of the foundation. I have. And I just consider the foundation to be part of my family. I feel somewhat, this is my personal feeling, somewhat indebted to Gordon Gund and what he has done for all of us to have the ability to, in our lifetime, to maybe have some treatments and cures. So lots of times people don't have the ability to make a financial gift during their lifetime, or if they do, maybe it's not as large as they would like. But a legacy gift is something that everybody can do because you don't need the money when you're gone, right? Of course, you should take care of your family. And I have 2 daughters and 2 granddaughters and a third on the way soon. And I'm taking care of them, but they also know that the foundation is part of my family. And I'm carving out a portion as a gift back to this organization that has meant the world to me. And hopefully you feel the same way. And I just really quickly want to say, you should feel so proud of anything that you give to the foundation financially. Our leadership is cutting edge on everything that we do. We have this retinal degeneration fund, the IRD fund, that is a multi-million-dollar fund that funds research. There's a gap in the science world between the lab and the clinic. And we invest in these companies, so we actually get a return on our investment. I'll give you one quick example. We invested about $3 million in a company. That company was purchased by a larger biotech pharmaceutical company, and we have already received $8 million back to the foundation as part of our investment. That's what it's all about. That goes right back into research. If all the milestones and benchmarks in that purchase are met, we stand to receive back over $20 million for our $3 million investment. So that's the type of leadership that you have at the foundation now. I would encourage you to seriously consider, get your affairs in order, your end-of-life affairs in order, which you should be doing anyway. Think about the foundation as being part of that. If you want to get a hold of me, Alyssa, if Alyssa's on the call, she knows how to get a hold of me, our chapter president, certainly Andrea and Linda. I'd be happy to help you. And thank you guys so much for everything that you do for the foundation. It's incredibly important. And I want to turn it over to Rishi. And Rishi, we are thrilled to have as part of the foundation family, our new human resource director. And I was privileged to be part of the interview committee to interview Rishi. And it's super cool in that we didn't steal you, Rishi, but we have her from the Walker Art Institute right here in the Twin Cities. And I think the very first thing, Rishi, that I had you do at the foundation before you came on board is she drove me up to an Albertville Lions Club meeting one night to make a presentation. So she was indoctrinated very quick into what we do to try to raise money. So Rishi, we're thrilled to have you, and I'm going to turn it over to you.
John, this is Andrea. Thank you so much.
Sorry, I stole that from you.
Oh, no. That's okay. No, that's okay. That's okay. John, I just wanted to thank you for sharing this. And it is such important work that you do. And thank you for sharing a little bit more about that. I think Rishi was able to join us. And Rishi, if you're on here, we're so glad to have you with us. And are you able to are you on here, Rishi? I just want to make sure before hi.
I'm having a little bit of audio technical sort of mishaps here, but I am here, and I heard John, and I'm very happy to be here. And in my short tenure here, I've had the great opportunity to really meet a lot of individuals inside and outside of the organization. And is it okay, Andrea, if I share sort of some of the things that we've done? Or?
Oh, of course, Rishi, please do. Yes.
Okay, because one of the things I'm really excited about is that the entire organization really came together and really articulated our organizational values through a lot of discussions and a lot of collaboration, and truthfully, just asking a lot of questions and listening and talking to one another, we were able to come together and identify 6 organizational values that we've been having a lot of conversations about, and they're not quite finished, but I thought I'd just introduce them to everybody. And I can't bring them up. I wish I could, so that they could be seen by those who might be able to see them, but I'm just going to read them through. And hopefully you'll be able to identify with them. And if you have any questions, you can always talk them through. But the first one is passion for our mission. And I'm going to add a little bit of context to each of these values. So the passion for our mission, because, our organization was founded on understanding, empathy, support, and hope. And this continues to give us purpose and fuel our motivation. We are one team collectively committed to the science, driving research forward to treat the entire spectrum of retinal degenerative diseases. That's our first. Our second is that we're relationship focused and we care. We recognize that our work is not within the confines of an office, but within the relationships that we establish and nourish. The third one is accountability with integrity. We make every effort to perform with uncompromising honesty and integrity in everything we do. It is through responsible actions and sincere, committed relationships that we build trust. The fourth one is that we're groundbreaking and risk-taking. If we do what always has been done, we will never progress. Taking risks allows us to reach possibilities that have not yet been imagined and improve the status quo through our work. So we are thoughtful and strategic. So we look to avoid mistakes and recognize that sometimes failures lead to breakthroughs. So all of that is how we consider groundbreaking and risk-taking. Accessible and equitable is our fifth value. We recognize the imperative for an open and flexible approach to how we work. We seek to empower equitable, accessible, and inclusive conditions that highlight the strengths and celebrate the differences of all individuals. And then the final one, and these, I should have said right up front that these aren't like in order necessarily of importance. They're all important. But the final one that I'm reading out is collaborative inclusive. We believe in the importance of positive interactions and being valued for who you are. We value diversity of cultures, abilities, upbringing, education, and experiences, and know that including varied perspectives makes us stronger as a community, and believe that diverse community of people in different points of view make for better outcomes. So I wanted to share those. So those are the 6 values. Ta-da! And you know, they really did come together through collaboration. These are the words of staff members. So this isn't something that was sort of purchased and brought to the organization. And it's been a wonderful process to be able to hear from staff members who are so committed and so talented in what they do. So that's obviously, I'm just really proud of that outcome, and wanted to share with you just a little bit of the journey that we went through. So is that okay, Andrea?
That's wonderful, Rishi, and thank you again so much. We were excited to share that you're local to this chapter. Yes. Yes.
I should have mentioned that. Yeah. And so I was out walking my dogs because, you know, it's so wonderful and beautiful today right now. And actually I had a mishap with one of my dogs, so I apologize that I'm late. But yeah, it's so wonderful. I was hoping to the opportunity to be with you all in person at some point, and I look forward to that. And there's something coming up too on Monday that I hope to see people at.
Yeah. Wonderful. Rishi, thank you for being with us, and thank all of our staff, Linda and John as well. We're just so glad to have a great team for this chapter. So let's move right along. I'd love to turn it over now to our chapter president, Alyssa Olsen. This would be a great time to meet our new Twin Cities chapter leadership team. So Alyssa, good morning.
Good morning. Good morning, everyone. Like Andrea said, I am Alyssa Olsen. I think I have introduced myself to many of you via email, but it's nice to be all together virtually this morning. I recently took over as president of the Twin Cities chapter. And just a little bit about me. I think I said this in one of my previous emails, but just quickly, I found the foundation, I guess it was 7, maybe 8 years ago now, after my dad was diagnosed with AMD. After his diagnosis, I was kind of frantically searching for resources and support and doctors and, you know, kind of all that information that you seek out after a diagnosis like that. And that is how I found FFB. And since then, we've had several family members, unfortunately, also received the same diagnosis. So we are not strangers to vision loss, unfortunately, but that is kind of how I found the chapter and FFB, and I guess what keeps me involved. So that is a little bit about me, but we also, just like Andrea said, assembled a leadership team here, and they will also briefly introduce themselves. Jason, if you want to go ahead and take it away.
Yeah, sure. Hey, everybody. My name is Jason Stonestreet. I am going to be the education chair. I guess I should say I am the education chair, proudly. I'm excited to be stepping up my involvement with the foundation. I found the foundation coming up on probably 10 years ago, around the time that I was formally diagnosed with cone rod dystrophy. I quit driving around that time, so that was 2011. and was just kind of the same as Alyssa, looking for a community and some resources. I didn't know anyone else who dealt with vision loss, just no one in my life. I'm an isolate in my family. So I was just kind of looking for a community. So I found the foundation. I met Julie, our former wonderful president of the chapter. Had lunch with her for a couple times, and yeah, I'm just looking to get a little more involved. And I think this is a great opportunity to do that. On a personal note, I work in market research, actually, as a retail industry analyst. I live in Maple Grove with my wife and 2 sons, and I'm an endurance runner. I actually just ran my first trail ultra marathon, which was 31 miles. So that was quite a feat, I guess, for someone with low vision. But it just goes to show you can really do anything that you want to do, anything that you can think of, any activity or profession. There's someone out there with low vision getting it done and doing a great job. And I try to live my life that way, just looking at all the opportunities out there instead of dwelling on the things that I maybe can't do or can't do as well as I used to. But that's a little bit about me. I'm excited to serve as education chair, and my job will be to network in our community to find experts like our guest speaker today to bring more information to you guys.
Thanks, Jason. Tom and Judy, I think, yep, I see you there. If you guys want to go ahead and introduce yourselves. Might have to take yourselves off mute though.
Okay.
We good?
Yep,
There we go.
All right. Well, I'm
Hi.
Judy Messina,
I'm Tom.
and we decided we're going to work together this year as your resource chair people. This is new to us, and we're very excited about it. We have a real passion for finding out resources. We know what they've meant to us, and we know what they can mean to all of us. And we know that all of you and all of us together hold a ton of resources that would be helpful to each other. So we're anxious to work on that this year, pull it together, and help you in any way that we can. A little bit about us. We live in White Bear Lake. Our first meeting was about 10 years ago, I think.
Yeah.
And we first met at a meeting just like this at Vision Loss Resources when Dr. Aizi was speaking. And we found the group to be so incredibly warm and welcoming and supportive that we just kept coming to more and more meetings, and haven't been overly involved other than attending things, but we're looking forward to this year to becoming more involved. We've got 2 grandchildren down by Andrea in St. Louis area. So we are down that way quite a bit, actually. As far as vision loss, I have Stargardt's disease, had it as a young child, but continued to have decreasing vision. It still continues to decrease, so I have quite limited vision at this point. And we together are members of the United States Blind Golf Association. We did our first tournament last year in northern Minnesota, Fergus Falls, and Tom is my coach for golfing, and he's awesome. So anyhow, we do enjoy that kind of stuff and getting out and walking and cooking, all kinds of stuff like that. So again, we're anxious, right? Very anxious to be here to work with you. Yeah, we're anxious to get started and work with all of you. And if there's anything you need, let Alyssa or Andrea know, and we will jump in and do our very best in any way that we can.
Thanks so much, Tom and Judy. We're so lucky to have you guys. Last but not least, Seth Larson. If you want to introduce yourself.
Hi, everybody. I'm Seth Larson. I live and work in Eau Claire, Wisconsin. I have a wife and 3 young kids, 2 of which have Usher syndrome. So basically finding the foundation for the first time came from our first diagnosis in our family. As soon as that happened, we basically began scouring the internet for resources and information and stuff like that. And we were quickly led to the foundation, and we kind of learned how many great things that we're doing here. So, that was about 7 years ago. That year we started raising money and doing the vision walk every year. A few years after that, I began helping out on a committee that plans the vision walk. And basically our family is just so thankful for all the things this foundation has done. We basically were looking for any other ways to give back. And when this opportunity for the revenue chair came up, we were happy to help out and continue our involvement in the chapter. So nice meeting everybody.
Great. Thank you, Seth. Well, that kind of rounds out the leadership team. We're so excited that everyone agreed to kind of take this on and work together. And we're excited to see what we can make happen. So thanks for everyone for being here. And now we will move on to what kind of brought us all here. We are so pleased to welcome Dr. Brittni Scruggs as the guest presenter today. She is a board certified adult and pediatric vitreoretinal surgeon with Mayo Clinic. Dr. Scruggs works with a variety of IRD patients and is extremely knowledgeable about IRDs, genetic testing, and clinical research. She is an active member of the Inherited Retinal Degeneration Research Team and spends time teaching residents and fellows. Her research focuses on the optimization of gene therapy and cell-based therapy for improved safety and efficacy in patients with retinal degeneration. So we're so grateful for her to be here. And we are so excited to hear what you have to say. We're just sharing some slides quickly, and then we'll get started.
See my slides okay?
Yes, thank you.
Yeah, perfect. Okay, thanks for having me. It's wonderful to be here and to meet the leadership team, and I hope to get to know all of you better. I am new to Minnesota, so I currently live in Rochester, but I moved here in August from Portland, Oregon. I previously was at Casey Eye Institute at Oregon Health Science University. And then prior to that, I was at Iowa, in Iowa City. And before that, I was at Tulane University, where I did my MD and PhD. So I've kind of been all over, and Mayo hopefully is now my forever spot as I build my practice. So just before we get started, a little bit about me. So my day and my week is very full. So I am both a surgeon and a clinician and a researcher. So I have one full day in the operating room. And then I split my clinic between pediatric retina and adult retina with a half day a week of clinic dedicated to inherited retinal diseases. I partner with Dr. Scamenti, who's a medical geneticist at Mayo Clinic. And my clinical partner is also Ray Iezzi, who I know many of you know well. So thanks again for having me. This talk is hopefully informal. I do have slides, but most of the slides are mostly so you don't have to keep looking at me. It's just something to look at. For those who do have low vision, I will, discuss everything that is on the slide. And so hopefully you enjoy the discussion. We can have some good, fruitful conversations in the near future. So I was hoping to talk about gene therapy and in general regenerative medicine for retinal degeneration. I want to start by just kind of talking about the learning objectives. So I was hoping to first kind of go over how gene therapy is being used in inherited retinal diseases. And then we'll summarize their repair mechanisms for cell-based therapeutics for the eye. And then if we have some time, briefly, we can discuss other regenerative approaches and clinical trials to restore sight. So I like to start with cases because I think it's important to kind of set up why this is important and also give you a little insight into my life and what I deal with. What are the questions I get on a daily basis? So like I said, I see kids and adults, which is a really fun thing for me. I get to see everyone. But it's common for me to walk into the clinic and immediately I'm getting ideas about what the diagnosis is. So here's a child with dark sunglasses. So immediately I know that this patient is light sensitive or potentially the vision is decreased with light. And so it's common in our clinics to get imaging. And so this is the retinal imaging, the OCT of this child. And immediately I know the diagnosis, right? So the imaging plus the clinical history together kind of points to a diagnosis of achromatopsia, which for the point of this talk is not necessarily important. But what is important are the questions that I get in clinic. So the first one is this inherited? So parents and even adult patients want to know, is this something that I can pass on to my children? Or for families who are still planning a family, is this something that potentially we should consider IVF? So inherited disease, it's very important to get an accurate diagnosis to answer this. Second, it's very common for patients and families to ask, is this progressive? What is my prognosis? And they want to know, what is it going to look like in 10, 20 years for me specifically? And so I want to have a very thoughtful answer to that question. Third is, how do I optimize my vision? I want to increase my quality of life. I want to do the hobbies that I no longer am doing, that I used to enjoy. These are questions I get, and they're hard questions. And so I want to talk about some of those resources as well. And then finally, is there a cure, right? That's why we're here, talking about research and ways that we can optimize vision using unique, new, novel therapies. So I hope that today we can talk about all of these things. You know, we don't have a ton of time to get into every single question in depth, but hopefully we can discuss further. So when I'm seeing patients, I have to do a thorough exam because it's important to know exactly what's causing the decreased vision. So I'm looking at the front of the eye, I'm looking for inflammation, for cataracts, looking in the back of the eye to determine what the optic nerve looks like, what the blood vessels look like, whether or not they're retinal detachments or tears, or even swelling inside of the retina. So all of these things are actionable, right? So it doesn't have anything to do with clinical trials or gene therapy or stem cell therapy, but it's potentially something that needs to be treated in the moment. So a lot of patients who have inherited retinal diseases also can have processes that require immediate attention, potentially eye drops for pressure or eye drops for the retinal swelling. And so these are things that I don't want to miss. And so the eye exam is extremely important. It also helps me with diagnosis and figuring out what genes I need to test for genetic testing. And then for patients who are in these clinics, it's common to get a lot of testing, and it might seem daunting, it might seem exhausting, and I agree, it probably is. I share this because it's very important for us to have baseline testing, both for clinical trial advancement, so we have a good baseline, but also so that we have multiple data points over time. So serially, we can determine if there is progression or if potentially this is a stationary disease. It helps us answer the question of what is my prognosis and is my disease progressive? And so we commonly will get studies that involve looking at the electrical signal of the eye to determine how the rods are functioning, how the cones are functioning, and then visual field testing to determine if there is progression of the peripheral vision or central blind spots. And so back to the case of the little girl sitting in clinic with the dark glasses, the electrical signal immediately shows us the answer. So the rods are functioning very well, and then her cones are flat, indicating that the cones aren't working. And that's why in the light, the vision is very poor. And so achromatopsia is a stationary disease. It's a cone disease, and these patients are day blind. I could have chosen any case kind of as the case presentation. Retinitis pigmentosa, a very common disease that I treat and see in clinic, is kind of the opposite. It's more night blindness. But either way, these patients are asking the same things. What can I do to improve my vision? And is there a cure for my disease? And so hopefully this sets up the next part of the talk. Vision rehabilitation, regardless of the disease that we diagnose, is very important. So at Mayo Clinic and around the nation, there are low vision specialists. They're experts in vision rehabilitation. So as an inherited retinal disease specialist, I partner with low vision specialists on a daily basis. I could not do my job without them. And so it's important to listen to patients to determine what is bothering them and what they no longer are able to do, and try to figure out how we can optimize vision. So that might start with a simple refraction, right? Optimizing the glasses or contacts, or getting the right contact. For patients who are light sensitive, maybe the contact lens needs to be tinted. For patients who are having trouble reading or looking at recipes or whatever it is, maybe using a good magnifier that has good lighting with increased contrast. or potentially getting patients plugged into state services, increasing their mobility, having white cane training, et cetera, or getting them wearable devices or a telescope for driving, or even having a driving assessment with an occupational therapist, which there are many in the area, or just getting them involved in support groups so that they're in a community of people who are asking similar questions and dealing with similar life challenges. So vision rehabilitation is extremely important with or without clinical trials. So not even thinking yet about gene therapy or stem cell therapy. It's important to optimize the vision now. And so that's something that I commonly refer for. Gene therapy, which I think is one of the most exciting parts of medicine, of all medicine, not just ophthalmology, is something that I wake up thinking about on a daily basis. This is what I train for. So I did my MD and my PhD at Tulane, and my PhD is in gene therapy and stem cell therapy, specifically for neurodegenerative diseases. And I went to Iowa specifically to be trained under giants in this field. So I trained with Ed Stone, Stephen Russell. I trained with Ian Hahn, Elliot Stone. Some of you might know all of those people. And then I did my, sorry, I'm going to go back. So I did my fellowship training in Oregon and Portland to train under people like Mark Panisi, Paul Yang, Andy Lauer, and Steve Bailey, all really amazing gene therapists and inherited retinal disease specialists. So as a fellow, I had the opportunity to be a part of over 50 gene therapy surgeries. And so I also did, probably 1,200 cases as a fellow, as primary surgeon, but the gene therapy surgeries were the ones that really made me go home and just say, this is why I do what I do. It's hard not to get emotional talking about this because we see patients who are struggling and have low vision. And then after the gene therapy, their quality of life is so much better. Some of the patients came in, they're like, I can see my children for the first time. And it's a game changer. So I want to talk a little bit about gene therapy. So in this photo, for those who can see this, this is an actual image of one of our surgeries. And so how gene therapy usually is done in clinical trials today is with a subretinal administration of the gene therapy. And so what we do is a full vitrectomy, which is removal of the jelly, the vitreous in the eye, and then use a very, very small gauge cannula to inject the supernatant or the viral vector, the solution, if you will, that has the virus underneath the retina. So that's a potential space. So you're actually making a retinal detachment. And I explain a retinal detachment to my patients. It's just a blister. It's a blister under the retina. And we intentionally are putting fluid in that space. The detachment or the blister resolves after 1 day. It's very quick. So we make the blister and it goes away. But what happens is when you inject the viral vector underneath the retina, it infects the cells. So it actually is infecting, or we call it transducing the photoreceptors. So the cones or the rods, usually within the macula, the center part of the retina. And that transduction, that infection of the photoreceptors jumpstarts the cell to produce the gene of interest, the gene that potentially is not working well, it's faulty. And expression of this gene that's now new and healthy allows the cells to be restored in their function, which allows more light to be transmitted to the brain, giving higher quality, higher contrast, and improved vision in a lot of these cases. And so I could talk for literally hours about the actual surgical technique of subretinal blebs, because this is something that I've studied over the last few years of how do we improve the efficacy, but also the safety of doing this. And we're still learning and we're still adapting and figuring out how to do this the right way. And even since Luxterna was FDA approved 5 years ago, we've changed the way that we've done the surgeries, and we're learning from our experiences. So I wanted to share a few photos here for those who can see this. On the left side is an image of a mouse that I injected with my colleagues at Iowa in the DRAC lab. And so the green here is the actual transduction of the retina. So the viral vector specifically changes any cells that are transduced to green. So you get this visual cue of that's exactly where there's, increased gene expression. And then if you actually do a cross section of the retina, which is the right side of the image, the animals that didn't have the gene therapy, where the arrows are, there's no transduction. And then all of the animals that were treated, you can see the red is lighting up here. So just kind of showing you that it really does increase gene expression almost to wild type levels. And this is what we're trying to do in clinical trials to date, is to just jumpstart the photoreceptor function. And so, as most of us know, the first FDA-approved gene therapy is Luxterna, and I've been a part of many Luxterna surgeries. And like I said, it's just one of my favorite parts of my job is to be able to work with patients in this way. Because there is now an FDA-approved, it really does allow other medicines to be in the pipeline. And I'm hopeful, as a retina surgeon, also as an inherited retinal disease specialist, that many medicines and gene therapies that are in the pipeline, that are in, say, large animal models or clinical trials, are soon to be FDA approved as well. It's just we are not quite there yet. But this Luxterna medicine also is subretinally administered, so injecting it under the retina. We're learning through our experience how to decrease inflammation. So there's a term called gene therapy associated uveitis, which is just inflammation in the eye. And that's also something that we as clinicians need to combat. So we don't want to give therapy trying to cure blindness, but then cause worsening vision because of inflammation. So we have to, perioperatively do a regimen to decrease that inflammation. And then, as I said, we continuously are getting long-term data. So I recently was at an FFB sponsored symposium in Denver last week, and that was in conjunction with Casey Eye Institute. And there were a lot of people who shared real world data on Luxterna and specifically subretinal injections, noting that over the course of months or years after these injections, we are actually inducing atrophy. So loss of the retinal tissue. And there are areas that we weren't expecting would happen, that there are big, what we call chorioretinal atrophic regions. And so this is good to know, right? We can counsel our patients. We can explain the risks and the benefits of all of these therapies. But I think we will continue as the years progress, understanding more and more, how do we do these surgeries better? And how do we decrease the risks for our patients? And so I wanted to switch a little bit to another patient. All of these patients are patients that I've seen recently. So this is an OCT, a cross-section of the retina. And although there are subtle changes, the takeaway here is it looks relatively normal, despite the patient having pretty significant central vision loss. And so this is important because if the photoreceptors are still there, they're still present, even though they're dysfunctional, even though they're causing vision loss, if they're still there, they're a candidate for gene therapy. And that's a really important takeaway from this talk, is that if the photoreceptors are present and we know the gene, then that's a candidate for potential gene therapy. It's when the photoreceptors are missing, when the disease is advanced to the point that the photoreceptors are gone, then no longer would gene therapy be appropriate. Then we need to talk about other therapeutics, which I'll talk about in a minute. So this is a patient of mine with X-linked retinitis pigmentosa. And so this patient has progressive tunnel vision, where the peripheral vision is fairly densely affected, where in the central vision is excellent. So around 20/30 normal vision centrally. And so you can see these visual fields right in the center are white. And then surrounding it, we call this a ring scotoma, where it's very much affected. So this patient would be an excellent patient for gene therapy because the central photoreceptors are present and are able to be infected or transduced. Okay. And so this is definitely something that a lot of people are thinking about, is how do we treat retinitis pigmentosa? And so there are many active gene therapy trials around the world. Some of the active trials in the US include achromatopsia. So the adult study recently closed, and now they're enrolling children between the age of 4 and 8. X-linked retinitis pigmentosa, there are multiple industry trials to date that are currently active, including the site at Mayo, which will be enrolling hopefully in the next few months. There are several choroideremia trials. Some include subretinal injections, which are closed, but they're analyzing the data. And then other trials that are active that are intravitreal injections. And so that's just an injection in the eye, and it does not involve the major surgery that I explained earlier. I put this link on here to Opus Genetics because this is, of course, a partnership with FFB of funding very rare genetic variants for gene therapy. And so this is a way for patients who maybe don't have, the more common retinitis pigmentosa or choroideremia or achromatopsia, for them to be a part of clinical trials. And so this is a wonderful initiative to put it as a priority for these orphan diseases. And then I just want to mention that there are so many 40 plus large animal studies in non-human primates, so like rhesus macaques or Japanese macaques. There are a lot of pig studies, all of which are showing really promising results for a lot of gene therapies, including rare variants. And we're very close to opening more clinical trials around the nation as a result of those large animal studies. And I thankfully was able, as a fellow, to be involved in some of the rhesus macaque and Japanese macaque studies in Portland, Oregon, at the Primate Center there. As a resident at Iowa, I was involved in some of the pig surgeries, and at Mayo, I'm currently a pig surgeon as well. So I have about 30% protected time for research every week. And one of my jobs in partnership with Dr. Ayezi is to try to perfect some of these surgeries and techniques using the pig model. And I have a pig operating room at Mayo. There are many gene therapies that are now closed, and that could be for one of two reasons. One is maybe the gene therapy didn't work, or it wasn't safe and is not going to be continued. Or second, it's closed because they met their patient numbers and now they're currently analyzing the data. And so I would, that's kind of more than we can discuss today, but I would say with your inherited retinal disease specialist, it's important to talk about these things. What has worked in the past? What worked in the mouse? What worked in the pig or the monkey? Or what worked in human trials, or what didn't work? I think negative data, really important to talk about. Which gene therapies had increased inflammation, which ones actually caused vision loss in patients. Those are things that we would be happy to share with you. I think disclosing that information is vitally important to advancing medicine and clinical trials. So as I said, achromatopsia, the adult trials are closed for kind of analysis of the data. X-linked retinoschisis, the NIH had a trial recently that was closed as a result of inflammation. So patients started developing vasculitis and increased inflammation, and the trial was shut down. And so there are a lot of people, including myself, who are trying to figure out how to best make a vector for X-linked retinoschisis, and how do we best administer this therapeutic to the eye. Stargardt disease gene therapy is tricky. And so, ABCA4 is a large gene, and it's not amenable to being used with AAV. And so you have to use a different vector, or potentially a dual vector where you split the gene in two. And so the gene therapy trials to date for Stargardt have not been effective. But there are a lot of trials for Stargardt that don't involve gene therapy. And there is one I know that there are some industry trials that are actively working to develop a gene therapy for Stargardt. So most of the clinical trials today for Stargardt are specifically looking at vitamin A modifications and different oral therapeutics. There also are some inflammation injections for Stargardts, including complement factor inhibition, but those are not gene therapies currently. Usher syndrome has been actively studied, all different types. Ushstat was a gene therapy that was trialed years ago and was not necessarily effective. There now is an Ushther gene therapy that's being studied, but it's not in the US. So a lot of people are studying Usher syndrome, and I think we will get there. But again, it takes a lot of work to do these animal trials in large animal models to make sure it's safe and effective. And so other regenerative medicine strategies, for those who were on the Insight Forum talk yesterday, Dr. Mark Panisi, who was my old mentor, was speaking about gene editing, which is different than gene therapy. So gene therapy is more of a gene replacement versus gene editing, which is CRISPR-Cas9 therapy. You're actually editing the DNA. And so that is currently being studied in CEP290 LCA. And we won't go into that much today, but those who have questions, I'd be happy to field those. Unique RNA therapies are being used to date. Those are active trials for USH2A, CEP290, and autosomal dominant RP for the Pro23 His variant. And those are antisense oligonucleotide therapies. And so there are a few active trials, and Mayo is actively trying to become a site for that as well. Optogenetics is different. So that's using gene therapy specifically to target the inner retina. And so that increases the sensitivity of the inner retina and doesn't actually transduce the photoreceptors. So optogenetics is a way to increase contrast and light getting in the eye without actually doing subretinal injection and without targeting the outer retina. Lipid nanoparticles, kind of beyond the scope of this talk, but I put it here because it's being talked about a lot on the research side of things, of how do we get these really large genes into the cell without using viruses, right? Because viruses are potentially inflammatory and potentially are too small to house these large genes. So getting it into the cell in unique novel therapeutics is something that's being studied. Antioxidants are being studied as well. There's the NAC attack, which will be opening as a phase 3 trial this summer with Mayo being a site. That's going to be for retinitis pigmentosa. That is actually not gene specific. So that is anyone with retinitis pigmentosa will be a candidate potentially. And antioxidants is to decrease inflammation, decrease the oxidation and oxidative stress in the eye to hopefully make the cells that are present and functional happier. And so that is a way to do a regenerative medicine strategy without actually doing gene therapy. And then complement inhibition is commonly being used in macular degeneration and also in Stargardt disease. So moving forward, so this is a patient of mine, and looking at the back of the eye, the photoreceptor layer is missing. And so the inner retina is completely intact and looks wonderful, but the outer retinal loss is pretty striking. And so this is a patient that, kind of going back to our prior discussion, would not be a candidate for gene therapy. There is nothing to infect because the photoreceptors have already been lost. And I think that's important to have realistic expectations, because not everyone is a candidate for gene therapy, but this would be a wonderful candidate for stem cell therapy. And so stem cell therapy is not to activate the photoreceptors, but instead it's to replace the photoreceptors. So it's a cell replacement therapy. And so this is a schematic of what stem cells do. So stem cells can potentially migrate to areas of damage. They can engraft, They can engraft, which means kind of make their home in a certain location, and they can replace degenerative cells. They can also differentiate into various cell types, which is why this is really amazing technology. You can take cells and actually push them down the pathway of photoreceptors or pigment epithelium and then transplant that. Even more so, stem cells have really amazing properties where they're immunomodulatory, where they decrease inflammation, which is being talked about in so many different, therapeutics and clinical trials. How do we decrease inflammation, but also replace these cells? So moving forward a little bit, cell-based therapies, there's so much to talk about here. And again, this could be for a different talk, but I think when we talk about cell-based therapy, we need to talk about different types of stem cells. So you can get the stem cells from the patient themselves, knowing that the cells would still harbor the genetic change that is causing the disease. So they would still have the dysfunctional gene. So there are many studies looking at patient-specific stem cells and correcting those, potentially with gene editing like CRISPR-Cas9 therapy, allowing their patient stem cells to now be normal again. And so other types of stem cells to consider, you can get stem cells from fetus, like embryos. You can get it from umbilical cord. You can get it from bone marrow, adipose tissue. You can get it from skin. So you can take a skin biopsy of a patient and grow stem cells that way. So there are a lot of ways that we can obtain stem cells, and many trials to date are trying to figure out which one is the most appropriate one, both from an inflammation standpoint, rejection standpoint, and efficacy standpoint. So there's a lot to think about here. Second is autologous, which is from the patient. We just discussed that a little bit, and allogeneic, which means it's coming from a different patient, which potentially increases the risk slightly of rejection. And most of those patients will need to be on immunosuppression as if they're having a transplant. And then cell suspension versus cell sheets. This is something that scientists, clinician scientists talk about a lot, is what's the best way to do this? So cell suspension is essentially like taking cells in a slurry and injecting it under the retina or in the vitreous cavity. So you're not actually organizing it, you're just injecting the cells themselves. A cell sheet is where in culture and in the lab, we actually form a sheet of cells, which then could be taken and injected inside of the eye, specifically under the retina, to replace the cells, allowing organization and a layer so that potentially that could integrate with the retina. And then scaffolding is important. A lot of people are trying to figure out what's the best way to transplant these retinal sheets, either the photoreceptor sheets or pigment epithelium sheets. And so our team, including many other teams in the nation, are trying to figure out how to make biodegradable scaffolds and grow cells on top of the scaffold. So that is definitely something that's of interest to me and my team. And then finally, good manufacturing practice. You want to make sure that these are being produced in a way that's safe, decreases contamination, and that the cells that you're transplanting are what you think they are, and that they're healthy, and that they are able to change vision. If you're just transplanting cells that are not healthy or not the cells that you think you're transplanting, you could be doing a lot of damage to these patients. And then finally, immunosuppression. So all of us are trying to figure out what's the best way to move forward with clinical trials with stem cells. And that's something that we are working on at Mayo in the pig model. We're actually transplanting cells under the retina on scaffolding, and we're doing various immunosuppression to figure this out. So cell-based ocular clinical trials have been present for the last 10 years. There are several that have been tried. Most have not been effective to date, mostly because they haven't been using cell sheets or scaffolding. They've just been injecting the cells specifically, like individual cells. So the first bullet point is a human umbilical tissue stem cell line. And so that was specifically tried for macular degeneration. The team found that it was safe, but not necessarily effective. The second bullet point is human embryo-derived stem cells, so embryonic cells, specifically for macular degeneration and Stargardt. Again, relatively safe, but not necessarily effective. I think the most recent trial that had maybe the most talk about it, it was actually on the cover of multiple really impressive journals, was an RPE cell sheet that was transplanted on a membrane. And so these were allogeneic, which, as you recall, means coming from a different patient. And these were implanted for patients with really advanced AMD. And they found that patients who got these transplants maintained their vision. There wasn't a huge improvement in vision, but compared to their fellow eye that wasn't injected, they didn't progress at the same rate. So the tempo was definitely decreased, which was helpful. And so there's a lot for us to figure out here, but I think it's exciting. I think we have a lot of good scientists in the nation working on this behind the scenes. And so I want to end here. I think we're right at time. Is what hope can we as clinician scientists give patients with inherited retinal diseases? First, I want to just make sure everyone knows that low vision resources, even without clinical trials, super important to be established with someone who can optimize your vision now, right? Magnifiers, lighting options, telescopes, whatever it is that can improve your specific vision. I think it's very important. Second is getting the right diagnosis and talking about prognosis. So once we have a genetic understanding of your disease, we can talk about how does everyone else with that genetic change do over time. And then as we get data points with imaging and testing in clinic, we can talk about progression and whether or not the disease is stable, or maybe the tempo is faster than we would anticipate. And sometimes that warrants immunosuppression to decrease inflammation. Third is support groups and genetic counseling. I think it's very important to have a community of people to talk about. This is inherited retinal diseases, as many of you know, is extremely anxiety provoking, can have an increased risk of depression. And so I think support groups talking about the research available, kind of talking about the hope that we now have that we didn't have 5-10 years ago. I think this is wonderful. And then third, clinical trials. We have lots of clinical trials that are active now, some that are closed, that were recently active, that we're trying to figure out what the data mean. And then in the future, we have a lot of trials in the pipeline that are going to be coming from the current large animal studies. And so in conclusion, I think a timely and accurate diagnosis is essential, which is why in clinic, we try to do such a good, thorough exam, good testing, and genetic testing to figure out a diagnosis. Extremely important that the history exam and testing is all complete. Ocular gene therapy trials and stem cell trials are underway. I think it's important to work with an inherited retinal disease specialist to figure out which ones are safe. You know, I think it's also important to note that if you are in a clinical trial now, it might prevent you from being in a trial in the future that might be more effective. So I think it's important to talk through all of the different studies. How was this effective in the animal model? How was it effective in other humans? And have a really great understanding before joining any trial. The Luxterna, if FDA approved gene therapy, is a wonderful start, right? We now have FDA clearance. This is the first of hopefully many gene therapies that we can provide the patients. But I think it's important also, as I mentioned before, that we're still learning. We're learning how to do these surgeries. We're learning the outcomes. And some things are really quite surprising to us that we're finding 4, 5, 6 years out from these surgeries. Things that I think we're going to kind of continue to learn. So we're still kind of in the infancy of doing this. And then finally, effective therapy for inherited retinal diseases must correct with gene therapy or replace with cell-based therapy the photoreceptors. I think it's very important to distinguish that there are different patients with different disease processes that are going to require different therapies. Okay. And so with that, this is our team at Mayo. We have a lot of retinal surgeons and retinal specialists, but the three of us are kind of the team for inherited retinal diseases. Dr. Scamenti is one of our medical geneticists. We have multiple genetic counselors as well. Dr. Ray Ayezi is one of the inherited retinal disease specialists and a retina surgeon. And then I'm Brittni Scruggs, and I am also a retina surgeon and inherited retinal disease specialist. So with that, I'm happy to take questions. And I just want to say I'm so happy to be here. Thank you for having me.
Dr. Scruggs, we're so grateful to have you with us. Thank you so much for all this insightful information. At this time, this would be a great time to ask some questions from our audience. So if you'd like to, we have a small enough group, if you'd like to come off mute and ask your question at this time, feel free to do so. And we may have some questions from the leadership team as well. And if you'd rather not come off mute, you can put them in the chat and we'll share them for you if that would be better.
Hi, everyone. My name is Wing Nguyen. I work at Northwest Eye. I'm a COMT, Certified Ophthalmic Medical Technologist. I want to say thank you. Do you know anything about the future of intravitreal injections?
Yeah, there are several clinical trials that involve intravitreal injections and not subretinal injections. I've been a part of several of those trials. For Stargardt and macular degeneration, there's the Zamura trials for complement factor inhibition, so C5 inhibition. For macular degeneration, there's currently an active clinical trial through Janssen, which is J&J, and there's an intravitreal injection specifically for gene therapy. And so choroideremia has an active intravitreal gene therapy trial that's currently enrolling specifically for men with CHM. And then there are many in the pipeline. The X-linked retinoschisis trial that I mentioned was intravitreal actually, and that was the one that was shut down because of inflammation. I think it's important. I think it's a good question because it's important to distinguish intravitreal from subretinal. Subretinal, you're injecting it under the retina, and that's a potential space that's protected, right? So the therapy is kind of away from the eye that can react to inflammation. And so it's not as common to have really severe inflammation from those surgeries. But with intravitreal, you're just injecting either the gene therapy or the cell-based therapy directly inside the vitreous cavity, which puts it in direct contact with blood vessels, which increases vasculitis and inflammation. And I'm sure many of you have heard of the Florida team that injected stem cells directly into the vitreous cavity, and all of those patients went blind. And I would say that's probably the scariest thing in regenerative medicine to date in all of medicine that's happened. So intravitreal injections, although easy, I do 60 injections a day sometimes. It's easy to do. It might not be the right approach for some of these gene therapies that are a little immunogenic. So I think, one thing that we can consider is changing the route of administration. There are lots of people studying suprachoroidal injections, where we inject it not into the vitreous cavity and not under the retina, but actually inside of the blood supply, allowing transduction that way. So there's a lot to think about here. And I think that's a great question because these clinical trials are kind of all over the place, different routes of administration, different types of therapy. And we have a lot to learn.
Thank you.
Mm-hmm.
Ayana, do you have a question? Good morning.
Hi, good morning. Thank you for inviting me, and I really appreciate the presentation. I came in a little bit late because I found out late that it was happening, but everything that I've heard today has been very helpful. I wanted to maybe ask a question of how it makes sense to support. We are the parents of a son who was recently diagnosed. He's an adult son. He'll be 24 later this year. He was diagnosed with retinitis pigmentosa back in 2019. And it's just been, you can imagine, you're you're 21 years old and you're getting this diagnosis, and everything that you've experienced up to a certain point in your life is starting to make sense. I think he probably started to have symptoms when he was in high school, but we didn't quite put it all together until he went for his first eye exam back in 2019 to see if he needed glasses, because his central vision was perfect. So we never thought there was a problem before. He's trying to digest, you can imagine the emotional ride, and we do have a retina specialist in the Twin Cities that we see fairly regularly, but we're still just not quite sure how to understand whether or not, how do we connect with these clinical trials? Is he, I'm taking notes, I'm watching the things that you're sharing and just trying to kind of keep up with it all. But we're in an advocacy role. He has his own apartment, he works, and he's still trying to get his emotions around the fact that this is happening to him. So we're trying to be in a supportive role, and just wondering what advice,
Yeah, these are all good questions.
Yeah.
Very, very, very common emotions, common questions. Yeah. I hear you. So I think there are a few questions to tackle here. One is about how do we stay ahead and be knowledgeable about these trials when it's constantly changing, right? The environment's constantly changing. Some are closing, some are opening, sites are closing down, new trials are coming up. So My Retina Tracker is a wonderful program. Okay, so that's one thing that I think is really helpful. So I'll kind of share a little bit more about that. So for all of my patients who I see with inherited eye diseases, I will ask if they want to be enrolled in the My Retina Tracker program. And so through Blueprint Genetics, which is partnered with FFB, the My Retina Tracker essentially takes the genetic information of that patient, and if ever there's a clinical trial that's active that patient would be eligible for, the physician is contacted. Okay. And so it kind of takes away that stress of constantly needing to Google, right? Is there something now, right? And then 2 weeks later, is there now something, right? It takes away that for the patient, but also for the physician, because if there is something that's active, you'll get an alert. So I think that's one thing, just to know that there are programs available that are doing that work for you. Second is to discuss in detail every time that you see your inherited retinal disease specialist, what trials are potentially out there. I am constantly going to my various resources, one of which is actually just clinicaltrials.gov, which is available to any person. And so I will caution people who just heard me say that clinicaltrials.gov has every clinical trial to date in the US. They're not FDA approved, right? Some of these studies are much better than others. They're better designed than others. And sometimes it takes someone like myself to go through all of them and say which ones make sense, like which one is actually based on really good preclinical data. And it's sometimes hard to tease out which ones are appropriate, which ones would be good to apply to. So that takes a conversation with your specialist, honestly. So those are a few things that I think would be helpful. And then in terms of the support group and community, I would say get him involved as much as possible. It's important to talk about this. It's important to be real, right? And to talk about what you're stressed out about, and to talk with your specialist, be involved with the low vision specialist, like I said, because even though his central vision is really, really good, there are probably things that he struggles with and will continue to struggle with that his classmates and peers will not. And then another thing is the NAC attack is for retinitis pigmentosa patients. And that is a study that's being led by Johns Hopkins. And again, this is new. This is just FDA approved as of last month. And the phase 3 trial will be opening hopefully in the next few months. And so we think it will be helpful for people who maybe have retinitis pigmentosa, but have a variant that isn't currently being studied in clinical trials. And so that gives an option to potentially decrease the tempo of the progression. And so, antioxidants, it's an oral medicine. It's given 3 times a day. It will be a dose escalation. So a low dose, a high dose, potentially a placebo as well. And trying to figure out, is this actually decreasing the freight train, right? Is it putting the brakes on the progression by essentially decreasing inflammation? So there are trials even for patients who don't have a genetic diagnosis, but have a diagnosis of retinitis pigmentosa.
Thank you so much. I appreciate it.
Yeah, you're welcome.
Andrea?
Yes, John, go ahead.
Okay, sorry, I was trying to find the keystrokes to raise my hand, but I couldn't.
Oh, no, you're good. You're good.
Sorry if I look like a nerd with my hand actually raised.
No, you're good.
Okay, so a couple of things. This is John Cornell. I'm, for full disclosure, for those of you joined the call late, I do work for the foundation, but I also have RP and I'm down to light perception only. So I didn't catch the name of the parent, the last question, but I just want to throw a couple of things out for you, for your son. I think getting involved with the foundation, which you have done as parents, is critically important to know that you're not alone, to know that your son is not alone in what he's going through. And he's at a tough stage in his life. So I'll offer, of course, anytime, and I know a number of other people in this chapter on this call right now, be happy to talk to you offline. Reach out to Alyssa or Linda or Andrea, and they can put you in contact with me or one of the other chapter members, just to give you some support, because even though our mission at the foundation is research and public awareness, so many people gain a support component to it that it's very much worth staying involved. And I want to say this, not as a foundation staff member, but as just a person affected. And I hope it's okay, Doctor. You've done a terrific job. Thank you. I don't think it's realistic that people should not be going into a clinical trial with the thought that they're going to get cured or that it's going to result in a treatment. At the end of the day, a clinical trial is an experiment. It's an experiment on a human being, and there's risk involved. And Dr. Scruggs had mentioned all the things to consider before you jump into clinical trial. And I think that there does become this, we all get so hopeful that, oh, put me in a clinical trial, put me in a clinical trial. I'm going to get cured maybe. And yes, that's a realistic hope to have. But most of these things are all about safety. Just to determine if the procedure or the process is safe.
That's absolutely true. Thank you for saying that. Yeah.
Yeah, I want to temper the expectation on that. So particularly at your son's age, to jump into a clinical trial when he still has really good vision left, you really, really, really want to be careful and cautious about that and talk to a lot of people. So that's just my personal comment. And then, Doctor, if you have if this is beyond your area of expertise, I apologize and no problem. But your case number 3, I think you mentioned, was the one where the person had pretty much lost all their photoreceptors, which is certainly common with advanced stage RP. I would have thought that maybe optogenetics might have been the best course for that, as opposed to a gene therapy or stem cell based therapy. And if an answer can be weaved into so many of the people who don't know what their gene mutation is, or know what it is, and it's not one of those that's being studied, like Luxterna, right? You're only a candidate for that if you have Leber's congenital amaurosis with the gene mutation on RPE65. So that's a very, very few number of people. So can you say something to maybe give some hope to people for a gene agnostic approach to these treatments?
Of course. Yeah. That patient that I mentioned who had no photoreceptor layer left, we do know the genetic cause. of her RP. And that was more of a segue into why cell-based therapy is, you know, being used, is to replace that layer. But you are absolutely correct, that patient would be a candidate as well for optogenetics. And so at the symposium that I went to last week in Denver, it was amazing. They actually showed some videos. It was a French-based team, and they did optogenetics on 3 patients. And none of those, it's not gene specific. And so it's an intravitreal injection, and it's specifically targeting the inner retina to increase function and increase light sensitivity. And those patients do have to wear a photosensitizing headset, which kind of activates the optogenetics, like the gene therapy. And all of those patients, they showed videos of them, and it was pretty incredible. I think at baseline, they were light perception. And then when the headset was turned on, all of them were able to immediately reach out and grab the pin on the table. And I saw those videos for the first time last week, and I got teary-eyed. So I think that there is a role for optogenetics, especially in patients with advanced disease, including patients who don't have a genetic diagnosis.
Thank you, John, for that question and for your input. Looking at our time, we have just a few more minutes, so maybe we have time for 1 or 2 more questions. Don't be shy. This is the time. Dr. Scruggs is here. This is the time. We're all here.
Dr. Scruggs, I am a patient at Mayo Clinic, and I have inflammation in my eyes, and I have very good photoreceptors. I do have advanced RP, autosomal dominant type. And you had said something about non-clinical or I'm sorry, this is upsetting for me. You had said something about non-genetic testing types of clinical trials, that there are medications out there to take care of the inflammation in the eyes. Is that something which is still available, or what do you have to go through to find out about that?
Yeah, great question. Nice to meet you.
Thank you.
So yeah, I think that question, 2 parts. So the first part is inflammation where we can actually see it, right? Clinical inflammation.
Right.
And so that is common in inherited retinal diseases, and specifically retinitis pigmentosa. And sometimes the inflammation becomes so severe that it starts to cause worsening tempo and worsening progression at a faster rate than we would otherwise anticipate for just the underlying RP. And so there are different, it's tricky. There are different people who think different things, but some of the people I trained with, they would actually in those settings consider anti-inflammatory medicines, and potentially that would be like immunosuppression. In other cases, if it's just low-lying inflammation, that could be treated potentially with topical drops or just monitoring. The second part is the clinical trial aspect. And so those are based on the hypothesis that there's a low-lying amount of inflammation in RP eyes, maybe that we can't even see. It's that the rods start to degenerate, and by the rods starting to become dysfunctional, they release inflammatory factors, which then cause progression down the line of the adjacent rods, or potentially even in the future, the adjacent cones, all because the death, if you will, of the cells is causing this domino effect because of inflammation. And so the clinical trial that I was mentioning is the one that was started by Dr. Peter Campachero at Johns Hopkins. And he specifically is looking at NAC, which is N-acetylcysteine. It's a medicine that's been used for a long time in other parts of medicine as an antioxidant. So it decreases oxidative stress. And now he's studying it specifically for RP. And the NAC attack, NAC attack, is the clinical trial that will be starting soon. It multi-institutional over the nation, specifically figuring out if we can decrease that low-lying inflammation, can we actually decrease that domino effect, that progression? So thank you for asking that, because I think it's important to understand why these clinical trials exist, right? It's all hypothesis driven.
I must have misunderstood you. I thought that there was an ability to at least address the issue of edema without being part of a clinical trial. Because as you said earlier, if you're part of one clinical trial, then that negates your possibility for going for a future clinical trial.
It potentially can. It depends on the gene therapy. I'm hopeful that the clinical trial that involves oral medicines like NAC, which essentially is like any other medicine that someone would take, would not necessarily negate other clinical trials or decrease the ability to join gene therapy in the future. So oral medicines are a little bit different. But if someone, say, had a subretinal injection of a gene therapy, very common for that patient to not then be a candidate in the future for other like major interventions.
How long is this clinical trial at Johns Hopkins going to take, or do they have any idea?
Well, the medicine was just FDA approved recently, and I got an email maybe a week ago saying that we're going through the enrollment process at Mayo to become a site. So I'm hopeful that at the end of the summer, maybe early fall, we can start enrolling patients. And then, like I said, I'm one of two investigators on the trial at Mayo, me and Dr. Ayezi.
Okay, thank you very much.
Yeah, you're welcome.
Marion, thank you. And thank you everyone for your questions. We're coming to the end of our time together today. But if you have a question that you didn't get to ask, whether it's FFB related or a question for Dr. Scruggs, I'll put my email in the chat. It's just aharper@fightingblindness.org. I will be sending everyone a follow-up email sometime next week, as soon as this recording is ready, just with a little more information and some things that are coming up. But we really appreciate everyone joining us today. Dr. Scruggs, can't thank you enough for all the information you've shared with us. Just thank you for being with us. We're so glad that you're part of this community, and thank you so very much.
Yeah, thank you all.
Thank you. I hope everyone has a wonderful weekend. Enjoy the beautiful weather. I hear it's great weather there today. Thank you all so much for joining us. And if you need anything, feel free to reach out to me, and I'll help get you connected. Okay. Thank everyone so much.
One final